disappears. Okay, so again, I want to welcome everybody to the Resident and Family Support Council with the Zoom account being sponsored by the Illinois Pioneer Coalition. Thank you to the Illinois Pioneer Coalition for allowing us to use your account for this very important meeting. So today, we're actually going to be, it's fall, and we've been through many seasons of COVID, and we're in the fall season for our second time around. Experiencing fall with COVID. And so we want to make sure that everybody has, as we keep saying in this, throughout this meeting, is information is empowering to people so you can understand what is actually happening. And so we have our three experts on this topic from the Illinois Department of Public Health, the infection preventionist team, as we so admiringly call them. And that's Deborah Purcell, Karen Trimberger, and Dr. Kennard, who will be joining us, who have joined us on this call to tell us about what is going on now in the state of the state in regards to COVID. So I'm not sure who will be beginning. Is it you, Deb?
I'll start. Hi, everybody.
I'll get the screen up while you are.
Perfect. Happy fall. Thank you so much for the opportunity to come and talk. We're just going to give some updates today. Next slide, please. We're going to talk, it's a lot of this you've heard before, but more and more, I want to run through in general what's happened, what's currently going on, and some of the things that are really encouraging. So we're going to review a little bit of the evidence. This is going to be a little different than you probably normally have. I'm going to look at a systematic review that was just recently published on the 21st, which is a really good example of evidence-based research. And so then I'm going to also provide to you the most current CDC and CMS links from their September 10th guidance revision. We just heard on a call that there's more CMS revisions to come. We knew there were about vaccinations, but it sounds like there's visitation changes that are coming as well. We don't know about that. We don't know anything, but at least it'll give you a place to start as far as looking at new CMS language. I'm going to talk a little bit about what types of licensed care communities are under this particular IDPH guidance that we're going to talk about. Going to talk about vaccine, boosters, third doses, monoclonal antibody therapy, and this updated, the upcoming IDPH guidance. And then I'm going to stop, end with some visitation stuff, and then we will take Q&A. Next slide, please. So we've learned a lot. Next slide, please. It has been a long and very difficult time. The focus in congregate care, we have, and Pioneer Coalition, Caregivers for Compromise, all of the advocacy groups have worked years and years to try to focus congregate care settings as person-centered with a home-like environment, because there are so many people that rely on the support of congregate care to help provide care for their loved one or their family member. The thing that happened when COVID came, and you all know this, that these interventions that we use that typically went for weeks have been required for months, and now at this point over a year. Social isolation has been especially difficult in congregate care. And we've learned a lot. And so it is a situation now where it looks like the light at the end of the tunnel may not be an oncoming train for much longer. Next slide, please. So I'm going to go back to core infection prevention practices because this is an old slide of mine, very old slide. It's over a year old now, but these, you can see these types of just strategic infection prevention measures are the ones that they're finding that still work. Vaccines. We are so blessed to have vaccines that are working to prevent severe hospitalization and death, which is basically what you look for when you look for a vaccine. it doesn't necessarily, and this is where CDC with their initial messaging, it was like, well, you're going to get a vaccine and it's ollie oxen free and everything's fine. But what they really needed to say as well was these vaccines are doing exactly what you expect them to do, which is prevent, in the most cases, severe hospitalization and death. And they are taking that much more into consideration with the newer guidance. Source control and PPE. There were 2 studies that just came out, actually, I think this week, that showed how schools that had mask requirements, that the cases and the outbreaks were definitely reduced in situations where masking was emphasized. Isolation, detection, screening, and surveillance, also very, very important. And they have modified some of that. Hand hygiene, always important, not just for COVID, but for a variety of other organisms, as is surface cleaning and disinfecting. The thing that we have a new appreciation about when it comes to congregate care is the importance of respiratory protection and ventilation. Next slide, please. So I wanted to differentiate, because you hear a lot about this, but generally when we're talking about residents, clients, members, visitors, cloth face coverings and procedure masks work just fine. This is actually a source from Johns Hopkins and the link is there. But for staff, they need a little bit higher level of not only protection, but source control. So procedure surgical masks and respirators, the N95 respirators. Next slide, please. So this is what I wanted to talk about. And so bear with me on this. This is a systematic review. Now, what a systematic review is you get a group of people together and they pick out search terms and they put them through professional search engines. So instead of just using Google or Google Scholar, they're going to use PubMed, they're going to use CINAHL Plus, they're going to use a little bit more fine-tuned. Instead of getting 1 million hits, you get a much more directed search. And so what they did is they put very specific what they were looking for, and the outcomes that they were looking for were congregate care settings that had at least 1 death or 1 case of COVID-19. And so they put their search terms in and they only came up with 700, a little over almost 800 articles. And then what they do is they get together as a team and they read them. And then if they meet the search criteria, then they include them in their study. And then they take the data from those and they sort of combine it. It's called a systematic review. And so they found 36 studies that were done well. So what we're looking at, and you are all very aware of this, in long-term care facilities, there have been 1.4 million cases and over 180,000 deaths. And that was mid-May. So that doesn't even include June through September. What they found is that basically what was happening in long-term care, you had this perfect storm of this microdroplet airborne transmission and asymptomatic spread, where initially people thought it was more like MERS or other types of coronaviruses where people had to have symptoms before they could spread it. But what they found, as we all know, people can spread it up to 2 days before they start showing symptoms. So they looked at this examination of the evidence, and their goal, this is why this is really important. The goal of these researchers is to better inform the frontline practice of exactly what's doing and policy, not only at the facility level, but also at the government level. Next slide, please. So basically what they found when they started looking at different facilities and what kinds of outbreaks they had is, and some of this is very logical, but they came at it from a very scientific point of view. Essentially, the larger the facility, and if they were in an area where there was a lot of COVID-19 in the community, those were the two strongest predictors of having cases and deaths within the facility. This is completely logical. It's totally logical. If you've got a lot of COVID-19 or a lot of any kind of disease outside, it has more ways to get in. The other thing that's very interesting that they found, the more staff a facility had, the higher probability they had of an outbreak. Also very logical if you think about it. You've got more people coming in and out, therefore there are more opportunities for the virus to get in. However, what they found is the facilities with outbreaks and they had higher staffing levels, those facilities were associated with fewer deaths. Also an important thing, if you're not really short-staffed and you have enough staff to cover the people who, if they happen to get COVID or to help support people, then you have a situation where they end up, being able to take care of the residents and they have fewer deaths. What was also very interesting was the nursing home compare, the 5-star ratings, the type of ownership, whether it was for-profit or not for-profit, and prior infection prevention citations didn't have consistent associations with COVID-19 outcomes, which shows that there are large opportunities to figure out what worked and what didn't work. Next slide, please. So their conclusions were better control of community spread would have been critical for mitigating much of the morbidity, which is sickness, mortality, which is deaths, long-term care residents and staff experienced during the pandemic. So if there would have been much stronger community control, it would have had fewer chances to get into the long-term care facilities. But that COVID-19 presented a novel problem, as you have all been right in the middle of, where everybody really had to adapt, very quickly by the providers and the policymakers, and also the people who live in the facilities and who care for those who live in the facilities. Next slide, please. So the reason I talk about that is that what you're going to see as far as the next steps go really depend on that kind of evidence. Those are the kinds of things that CDC looks at when they make changes. So the other thing that I want to talk about really quickly is the guidelines for nursing homes and other long-term care facilities. The guidance that's been out, the guidance that's getting updated. Its facilities is defined in the Nursing Home Care Act. So you're going to talk about skilled nursing and intermediate care, supportive living facilities or SLFs, assisted living facilities or AL, shared housing, sheltered care, specialized mental health rehabilitation facilities, intermediate care facilities, state operating developmental centers, medically complex developmentally disabled facilities, and Illinois Department of Veterans Affairs. So if you have a family member who lives in independent living, or if you have a family member, or you live in independent living, or you live in a community group home like a SILA, these don't necessarily apply. A lot of the strategies apply, but the licensure, the guidance itself is written for these types of care communities, not necessarily independent living or others. Next slide, please. So I wanted to make sure that I got these for you and we can put these links in. What CDC did on September 10th is they combined a lot of their guidance into 3 main pages. And what they told us is that these pages, even if they update things, these pages, if you use these addresses, these internet addresses, this is where you're going to find this. So they have recommendations to prevent SARS-CoV-2 spread in nursing homes. Next slide, please. Recommendations for healthcare personnel during the pandemic, the infection prevention and control. Next slide, please. And then this is how to manage healthcare personnel with SARS-CoV-2 infection or exposure. The one thing that we've seen that has really been in the CDC guidance that has changed, and they've actually strengthened it, is differentiating between vaccinated and unvaccinated persons. Next slide, please. This is the CMS. This is Centers for Medicare and Medicaid Services, and they also revised on the same day. They revised their interim final rules. So for the testing requirements. So this is the testing one. We're still waiting for the visitation one, and we have heard that there's also going to be a vaccination one that's going to come. We have not seen those. We have no information about that. Next slide, please. So Delta variant really changed the game. We thought June into July, things were getting better, and then things started ticking up again. And what we did find is that the VE vaccine effectiveness was not as strong against Delta as it was against the other strains of SARS-CoV-2. Next slide, please. And so what they found is that there were a couple of really good studies that the effectiveness, which means how it works in real life, declined down to 80%, which is still really pretty good. But you had a situation where all of a sudden you see some of this waning vaccine effectiveness and an increase in cases, breakthrough cases, which is not unexpected, but then also an increase in hospitalizations and unfortunately some deaths. Next slide, please. Even though it's still a very small portion of the vaccinated people, and unvaccinated people are at much higher risk than vaccinated persons. So this is something from the White House and from CDC. They were preparing for the booster vaccine. Well, we know about what's happening here. Next slide, please. So this third dose is supported. The booster increases the antibody titers by at least 10-fold. Right now, we are only talking about the Pfizer vaccine. This is the only one that's gone through the process. The Mrna and the J&J are coming, but right now it is a booster Pfizer RNA immunization. That's what they're talking about. Next slide, please. The other thing I wanted to show you really quickly, just because this is a really interesting thing, green is good, dark purple is not so good. And you can see Illinois is doing a really, really well here as far as having highly vaccinated populations and having lower percentages of hospitalization. So we are not running out of ICU beds like some of the other states that you've heard about, the tragedies that are going on where they're having to ration care because they just don't have the room, and in a majority of it is unvaccinated persons with COVID. Next slide, please. So basically the CDC backs the COVID booster plan. I know there's been a lot of confusion, but it isn't really that confusing if you look at it pretty straightforward. And this is off CDC's Instagram page. The decisions, 3 out of the 4 decisions made by Dr. Walensky aligned with Pfizer. So who's eligible after 6 months? People who are 65 years and older, long-term care residents and staff, people 18 and over who have underlying medical conditions, that's asthma, diabetes, and obesity, because we know that they have worse outcomes. People who are 18 and over who work and live in high risks, that's important for some of the congregate care settings with younger persons who live there in high risk settings, including healthcare workers, teachers, and grocery workers. Next slide, please. And this is Dr. Kennards. So I think she's going to give the next, talking about vaccine safety.
Sure. I just wanted to share some slides that I gave during our local health department. Every Monday, we have a statewide situational update call for the local health departments. There's 97 local health departments in Illinois, and primarily public health they're the boots on the ground, the ones who are delivering the public health services, and then IDPH provides guidance and support. So this was a presentation that I gave back in August. So next slide, please. I did want to mention, though, that there seems to be a tiny bit of confusion in Illinois that IDPH is not going to, we have adopted the recommendations of the CDC. Of course, we will not be giving different guidance than the CDC as far as the booster doses. So what Deb just shared with you is the recommendation, and the state of Illinois officially adopted that as our state policy for the booster doses. And I just wanted to make that clear because I think we've heard from a few places and some long-term care facilities that they weren't sure if we were going to issue separate guidance. We will not. We will follow the national recommendations for vaccinations. So I just wanted to run through a little couple of questions that we get a lot. And actually, Deb had found these excellent slides from the New Jersey Department of Public Health. Some people ask, how was the mRNA, and this is the mRNA vaccines, how were they developed so quickly? The truth is, and you may have heard this yourselves as well, they were already in development. You might remember back in the early 2000s, there was SARS-CoV, the first SARS, and there was a pretty terrible outbreak in Toronto. And at that time, we did not have a vaccine for it, but because of very heroic efforts by Toronto, by the police, by the healthcare workers, by everyone working together, they were able to identify cases, do the close contact tracing, just the same as what we're doing now, make sure people wore masks and put people into quarantine. One day they had 18,000 people in quarantine. It was a massive, massive effort. And they were able to contain it, so it did not become a global pandemic. But it was recognized, hey, this was a wake-up call. This could happen again, and here we are now with another SARS-type virus that's circulating. And so back when the first one occurred, well, 20 years ago now, the manufacturers began working on the mRNA vaccines. And so these has been in development for a long time. Anyway, then when it came time to develop a vaccine specifically for this particular strain of the SARS virus, they had something already in that they had thought of before and had been working on previously. Then there was, as you know, a full court press, so many people dying that they really put a lot of money, a lot of effort into doing this and doing the safety studies. And so there hasn't been any shortening of the safety studies. These were all done overlapping. And I'll show you, if you go to the next slide, please. Tens of thousands of people participated in the phase 3 clinical trials, which is when, first we tried on a smaller number of people, and then we increased the number of people that we're trying it on to make sure that it is safe. But tens of thousands of people participated over a year ago, and there has just not been major safety issues identified with these vaccines. So that's one reason why we are able to proceed full court press in the way that we are. The phase 4 is now where we are still continuing to monitor. We're still continuing to look for any problems that there might be with these vaccines, and we're just not finding them. Next slide, please. This is from the Advisory Committee on Immunization Practices meeting on July 22nd. They were specifically reviewing how are these vaccines being monitored. I'm vaccinated. My parents who are in their 80s are vaccinated. My children who are in their 20s are vaccinated. I, of course, want to know that these vaccines are safe. I want to know for my own family, for my own community, and for the other people I care about, my colleagues, the people who we are providing services for in long-term care and so on. But I personally have a vested interest in making sure that the vaccines are safe, because I've made sure that everyone that I care about and love has gotten vaccinated. So the COVID vaccines have been monitored under the most intensive vaccine safety monitoring in US history. So I just want to say that again, the most intensive vaccine safety monitoring in US history. Next slide, please. Hundreds of millions of doses have been given. You know, hundreds of millions of doses have been given globally. We're just not seeing safety issues with these vaccines. One of the ways that we monitor vaccination is through the adverse event reporting system. Anybody who gets any vaccination, for whatever reason, they got a rash, they had a runny nose, they felt achy, they had a headache, or even more serious issues, they can report it through VAERS. And that does not mean, and you can look up the types of things that are being reported in VAERS. This does not mean that it was actually caused by the vaccine, but it is one of the ways, one of the main ways that the United States gathers information from regular citizens on the street, from doctors, from healthcare institutions, all get reported into VAERS. And IDPH staff are monitoring VAERS reports for Illinois and the nation looking for trends. Next slide, please.
Oops, hold on one second.
No problem.
There we go. Sorry. Okay, there we go. Sorry.
The other main way is to actively look. So that's a passive, right? We say, here's a reporting system. If you have a problem, you can report it. And also we require doctors and other people who are administering the vaccinations or providing healthcare, they have to report it. But this is an active surveillance, huge health systems, 12 million people per year, actively going and monitoring what kinds of reactions they might have had. And I don't know if any of you who've gotten the vaccination signed up for CDC, they are periodically, and I was a little surprised just recently, I got my vaccine months ago, of course, they sent me a little note saying, so how are you doing? Have you had any problems? Have you gotten pregnant? You know, have you, how are you feeling? Any change? Have you been diagnosed with COVID? And so that's kind of a form of active monitoring too for people who've been vaccinated. Next slide, please. So these were the slides that were shown back in at the end of July at ACIP. And it's a little bit complicated, but I wanted to run through this. So there's two slides here looking at the risk of by sex, female or male, and then also looking to the left are hospitalizations and deaths that were prevented. And to the right would be anticipated number of cases of the complications that have been identified. And that's for every 1 million doses. And then on the right, these conditions do occur naturally. And so what is done is you look to see if there's any increased risk for the people who've been vaccinated over what might have occurred naturally. Guillain-Barré happens naturally after viral infections and other types of bacterial infection and so on. Myocarditis, young men have a tendency to get mild myocarditis that improves. And so you have to look and say, so we do see these things happening, but are there more because of the vaccinations? As you can see here, they've divided it by age group. So the top one is for the J&J vaccine. And again, these are for women. And so we're looking at the red is Guillain-Barré, which is the neurologic condition. If you get that after vaccination, sometimes that happens very rarely. Again, these are all extremely rare things that can happen. Typically you recover. And we did all hear about those rare cases in women of childbearing age who got the J&J vaccine and had the blood clotting. Very few cases. Again, that's a testimony to our extremely active looking for any kind of problem so that we can tell people that you have a 4 in a million chance out of every million doses. If you're in this age group and a woman, you have there might be 4 cases of this blood clotting. So, but then if you look to the left, you see how many hospitalizations in light blue and how many deaths in dark blue. And then again, we see the same thing with the mRNA vaccines, which are the ones that have been associated with myocarditis. So, No question, the benefit of getting vaccinated is huge and the risks are very, very small. Next slide, please. And this is then for males. And so you can see down here on the bottom slide, the risk for the myocarditis. Again, these were mild cases and they have recovered. We haven't had any serious complications that were ongoing in the young men that received the mRNA vaccines. But it can help you decide which vaccine you might want to get, other than maybe you don't want to get 2 doses and so you'd prefer to have a single shot. Next slide, please. And I think we'll be giving you these slides so you can look at them in more detail. I know that they're complicated, but the assessment then was decided that the benefits of COVID-19 vaccination far outweigh the potential risks. I can tell you that I feel traumatized myself. I am traumatized that more than 10,000 residents of long-term care have died from COVID. The vast majority of those were before vaccination. I can tell you that. But for me to continue to see unvaccinated individuals, staff in long-term care, putting themselves and their families at risk because of misinformation, I'm traumatized by that when I hear of the hospitalizations and deaths that are occurring in unvaccinated individuals when these are safe and effective vaccines. Next slide, please. There's a great page on the CDC website that goes into detail about some of the concerns that we hear about. The COVID-19 vaccine cannot give you COVID-19. It cannot cause you to become magnetic. It does not affect fertility. You are not going to shed it or release any components of the vaccine. What the vaccine is doing is making your immune system stronger so you can your body will recognize this virus and fight it off before you've had the unfortunate experience of having been infected. It's not going to alter your DNA, and it will not cause you to have a positive COVID-19 test, the PCR or the antigen. You will see it on an antibody test, of course, because that's the point, right? It makes your body make antibodies so you don't get sick, or at least you don't get as sick as you would have otherwise. Next slide, please. Vaccination during pregnancy. COVID vaccination is recommended for all people aged 12 years and older, including people who are pregnant, breastfeeding, trying to get pregnant now, or might become pregnant in the future. That's very important because pregnant women are more likely, just like for flu, to have severe illness from COVID-19 and unfortunate outcomes because of it. Next slide, please. CDC came out with this statement. After doing intensive review of all the evidence thus far, there is no evidence of increased risk for miscarriage after receiving the mRNA COVID-19 vaccine. The benefits of receiving COVID-19 vaccine during pregnancy outweigh any known or potential risks. Pregnant people should be vaccinated against COVID-19. And again, the same statement that I read you a minute ago. Idph sent this information out to all healthcare providers in a siren on August 17th. Next slide, please. This same statement came from the American College of Obstetrics and Gynecology. They are urging COVID-19 vaccination. Next slide, please. Recommends pregnant and lactating individuals receive COVID-19 vaccine or vaccine series. Pregnancy test isn't necessary because it is not known to affect pregnancy. Claims linking COVID-19 vaccines to infertility are unfounded and have no scientific evidence supporting them. Available data suggests that the symptomatic pregnant and recently pregnant patients are at increased risk of more severe illness compared with non-pregnant peers. And I think that might be my last slide, but you can go on to the next slide.
So just to let you know, when it comes to vaccines, IDPH put out a questionnaire to make sure that we had an idea on facility plans to make sure that if the residents and staff wanted the boosters and or have changed their mind and would like to, or haven't had the opportunity before and would like to have their primary vaccinations, how exactly that's happening. That the deadline for that was Monday, so that's just being compiled now, like yesterday. So, and it is being compiled. Many of the facilities are working with their own pharmacies and pharmacies that provided their initial doses, like Walgreens and CVS. The other thing I was going to say, those of you who have who live in independent living or other care communities, you might want to check with people to see if they are going to schedule clinics for boosters. Otherwise, there are a variety of places in the community you can get them, Walgreens and CVS, Osco, where the boosters are available. Next slide, please. So another thing we're going to talk about is monoclonal antibody treatment. Now, it's used to neutralize. Monoclonal antibody treatment is a very general term, but there are specific treatments for COVID-19, and it's used to neutralize the COVID-19 virus, prevents the progression of disease. The US government is currently supplying this at no cost to the person who's getting it. It is used for both treatment and post-exposure prophylaxis, which means if you've been exposed to something, you can get it so that you don't get sick. It can be given intravenously, but it can also be given subcutaneously, which is sort of like getting an insulin shot. So, you know, there are ways that it can be given in long-term care, or they can be sent out, you know, depending on if they can manage IVs. If it's a person who is sick, IV is the preferred treatment, but pretty much they can use either, depending on if there's going to be any delay. This would be for persons who are exposed or told they had a high level exposure in the past 7 days, or a person who has COVID symptom or a positive test in the past 10. Next slide, please. So this is a little busy, but basically it's a decision tree. So does the person have COVID-19, or were they exposed to somebody? Yes. If they're hospitalized or they need more oxygen than usual, like if you normally get 2 liters of oxygen and all of a sudden your air hunger, your oxygen need went to 6, then the person needs to have other treatments, not monoclonal antibodies. But if the person is at risk for disease, 12 years of age or older, so it is for younger people as well, and weigh 88 pounds or more, they may very well be eligible. And the risk conditions are older age, chronic kidney disease, chronic respiratory disease, immunosuppressant disease or treatment, diabetes, obesity, cardiovascular disease or hypertension, or other medical conditions or factors. So this would be something that you would discuss with your provider, with your physician or your nurse practitioner or your PA, but just know that this is an option. But as we saw before, there are time limits. So if you do have a positive test, this is something that you want to reach out to your provider to talk about. Next slide, please. So the new IDPH guidance, the core principles are going to be the same: vaccination status. It does make a greater difference in these newer guidance. The monoclonal antibodies, it's new content about that. Source control, Illinois has slightly higher expectations than CDC because of the executive order for source control. There's new content on community transmission risk, and your response to a positive in a healthcare personnel or resident, the immediate level of response may change based upon contact tracing, which I'll get into a little bit, or broader based approach. And then the visitation, dining group activities, that's all being updated. Next slide, please. So a broad-based approach, this is what you're used to. It's the current approach. Basically, it's facility-wide testing of all healthcare personnel and residents, unless the person's had it in the past, COVID in the past 90 days. And it goes every 3 to 7 days until no more positive cases for 14 days. This is what's happening now. Next slide. This is the new. So there will be a unit or a department level approach, which takes into account contact tracing. So you're going to base things on the unit where the positive case was found, or the department where the positive case was found. The thing that I want to reinforce and emphasize is that compassionate care, end of life, and essential caregiving still continues into the entire facility. That is not suspended. So if we are doing this, you're going to look at the place where the case, this is more logical too. Where did the case occur? You're going to,
hold on, I'm just.
Can somebody mute? Colette, can you mute? Colette, can you mute?
Muted her. I just muted her.
Okay. Oh, thank you. Okay, thanks. So you want to make sure that it's focused on that unit or that department. Going to test everybody there. And the testing schedule is going to be a little bit different, but if the healthcare personnel works on more than one unit, then you're going to want to use that broad-based approach again. Next slide, please. So I have a couple of examples here. So you have a dietary healthcare personnel that test positive. They only work in the kitchen. They don't go to the resident client units. Testing and contact tracing occurs in the kitchen because that's where the person is. And it might not affect anyone. You know, it would look at who has this person been around? Who do they take breaks with? Do they commute with somebody? Do they have a family member who also works there? But it might not affect the residents at all. But if you have a nurse who works on, like say on the second floor, they test positive, they don't float. Only the second floor would be considered that affected area. And it would then only be, if you have no more positive tests, it would only be those residents and staff who had higher risk exposures or close contacts to this nurse. Next slide, please. Giving you a little preview. The admissions and readmissions, you will also see a difference here. Unvaccinated residents must quarantine on admission. Vaccinated residents, the recommendation was removed. They do not need to quarantine on admission unless they're symptomatic. The new guidance does require testing to be completed regardless of vaccination. That's sort of where because we have seen vaccinated people break through. So there will be testing, but we're also working on a new risk assessment for visitation and overnight stays. And I so appreciate people's volunteering to look at it. When we got the new guidance, we've had to basically scrap and start from the beginning. So we're working on that. Next slide, please. And this is my last slide, but basically what I want to say is, and I want to reiterate this, compassionate care visits and visits required under federal disability laws are allowed at all times, regardless of the resident's vaccination status, the county's, the risk of that, whether it's higher or lower risk or an outbreak, or, and these are some examples that are considered compassionate care. This is straight from CMS. The resident who was living with a family before being admitted and they're struggling with the change in environment, grieving after a friend or a family member passed away, someone who needs this is where compassionate care and essential care sort of blend. Somebody who needs cueing and encouragement with eating or drinking, and they've experienced weight loss or dehydration, residents who used to talk and they're experiencing emotional distress, allowing a visit in these situations, and this is a quote, consistent with the intent of compassionate care. Also, in addition to family members, compassionate care visits could be conducted by individuals who meet the residents' needs, clergy, lay persons offering religious or spiritual support. This isn't an exhaustive list. You have to work with your provider, but we hear these stories and it's like, no, wait. It is it's a very interesting situation when we get told that people aren't allowed compassionate care visitation. So work with your facility. And next slide, please. I think that's my last.
Well, thank you so much. And Carrie, if you could just let me know if you see any questions. I know I had a couple of things that I did want to make sure that was just addressed. But Carrie, did you have anything in particular that I have monitored?
Obviously, I'm thrilled if it's going to come out saying that essential care is also that must. So is that the phrase? It's going to be read that essential care must be allowed to go on during outbreak? Because obviously that's one of our issues, is that everyone says, oh, no, you have essential, not compassionate, and they shut them all down. So is that going to be more clear, Deb?
I think Karen.
I was going to say, let me find it real quick. Go ahead and ask some other questions and I'll reread it.
Yeah, because I was going to say, because we're staring at it right now. Go ahead. Next question. Karen's looking for it.
Okay, great. Thank you. I know, so we've heard some rumors, and actually, in just as the lay people, that some facilities are making staff get vaccinated. Can you speak to that at all?
There are facilities that are making vaccination a condition of employment. Yes, that is true.
Does it feel like there's going to be any state intervention in on that, or no?
What do you mean by intervention? I'm sorry.
Will they be mandating it, the state, that employees that work in long-term care have to have vaccines?
I don't have any of this, Dr. Kennard, insight into that. That would be something that would come from the governor. So I think what we're faced with right now is the executive order that required vaccination or testing, not only in long-term care, but in all healthcare facilities. So that's the current status. And he has mandated vaccination for the state employees that work in 24/7 facilities, because those work for the state. But beyond that, and that has to be by October 14th. But beyond that, I have not heard of plans. That does not mean that they're not in the works.
Okay.
Hey, Lee.
Dr. Kennard, can you explain to
Kira
people?
has a question, Lee.
I'm sorry, go ahead, Kelly. You want to ask the question?
No, I was letting you know that there was a hand raised. Kira has a question.
Oh, okay. I can't see everybody's hands. So, Kara, you can go ahead and unmute yourself if you'd like to ask that question.
Hi there. Yeah, thanks so much for getting to me so quickly. So I am a community reintegration advocate. So I assist residents who are presently residing in nursing homes and long-term care facilities against their choice, and assist them in effectively transitioning into the community. And so I've witnessed this pandemic firsthand and how it affects the consumers I serve. As you likely know, at this time, facilities are starting to go on lockdown again, because, as it's been reported to me by the administrators, that a staff member has shown up to work positive. And as a result, they're at least doing partial, if not full lockdowns. And then as a result of that, they're cutting all visitation at this time, which actually makes it really difficult in a lot of ways, but also continuing that transition process. In Cook County would be through the Colbert consent decree. And so my question is, and this is just a concern, especially in terms of the quality of life and care for these residents. If there's a situation where we're having a staff member test positive showing up at the facility, and as a result, there's this lockdown, that then ultimately affects the residents, right? Because then they're quarantined to their rooms. They have to take multiple tests. They're not able to go outside, and they're also not able to get visitation. And so it seems like the consequence at this time is ultimately who's experiencing this burden, and the consequence are the residents. And so with us seeing this trend occurring more and more with nursing home lockdowns based on the results of one or two staff members, I'm wondering, what is the repercussions, or how are we making these nursing facilities accountable for this issue. Because I also do look at IDPH's vaccination rates. That I know you guys have a map and you can look at the different facilities and what their vaccination rates are at this time. And there are a number of them that are significantly low. So it really hurts my heart. And as others have said, it's traumatizing, right? Not only to myself, but the resident, that they're then locked into this facility. But I'm wondering, what are the consequences of the facility for this actually occurring?
Okay, that's really important that you're seeing that. Yeah, that is part of the thing that CDC and the new guidance, it's one of the reasons why vaccination is being taken more into account so that whole buildings don't go down. But even, as far as suspending all visitation, suspending everything else like that, the newer guidance talks about, they will allow, number one, people who are fully vaccinated, and this is in the CDC guidance right now, so it's not like I'm saying anything, out of turn. If people are vaccinated, they don't necessarily need to quarantine, which will be very important for exactly what you're talking about. The other thing that is made much clearer in the new IDPH guidance is that compassionate care, end of life, and essential caregiving are bundled more closely, to Carrie's point as well. But we're very aware of just how devastating this is. And to your point, Kara, about consequences, the Office of Healthcare Regulations does follow up if there are multiple reports or even one report of someone not being allowed compassionate care and essential care. And I know that because we're frequently involved in that. But just to let you know, it's one of those things where you do need to talk to the facility, because it may be a situation with this one particular person that there are other, how do I say it, circumstances. But thank you for supporting people, and thank you for supporting people for getting them out into the community.
Sure, this is here again. With respect, I fully understand CDC guidelines. So glad that you're following them. I'm just letting you know what's actually playing out in the facilities at this time. So, when I'm witnessing this firsthand as someone who's been vaccinated, and I've witnessed a resident who is vaccinated, who unfortunately, he has mental illness, experiences a number of different disabilities, and that was the antecedent factor for one of the reasons why he had a psychiatric breakdown, and as a result was transferred to a psychiatric hospital. So rather than the facility taking responsibility for their own issues and responsibility and for that occurring. So I'm just wondering, so when I witness a situation such as this, knowing that this facility or a number of facilities that I'm working with at this time are not following those guidances, these new and updated guidances that you're informing us of, who should we be reporting that to? Because something needs to be done and something needs to be changed about that. Because I understand there are rules, but things play out very differently within the facilities sometimes.
You're exactly right. And that's also too, when you can get in touch with the ombudsman and work through with the ombudsman and make sure that, if reporting what you see, that's really important. But those are really, really important points.
You can also file, go ahead.
Just to reinforce what was just said, that is a way to use your ombudsman, and we can then take that information and see if there's systemic, because if it's happening for one, it's happening for more. So we can then help advocate for all the people that live in that building and that individual as well. And then if it needs to be escalated then to the regulatory side of the Department of Public Health, we can assist with that process as well. So know that we are collectively trying to support through everybody's efforts through IDPH, the Ombudsman Program, the Department of Aging, to really support those that are living in these long-term care environments so that they do not get, for lack of a better word, taken advantage of by people abstractly trying to put rules out there that may have changed through the course of time, because these rules have gone through a lot of changes based upon the most recent information that that is known to those experts, such as those who are sharing information with us today.
And that,
So,
this is
Deb.
Karen, and I was just going to say one thing too. You can report it to regulatory, like what was mentioned. Deb and I have taken numerous calls and emails related to this. Sometimes though, what you think you see may not be the whole picture. So not that I'm necessarily defending the facility, but we don't always know the resident, the situation. Perhaps they were put in quarantine because they were a close contact or something like that. So we don't know the full story here, but otherwise we are happy to advocate for that. And sometimes it's just a call to the facility by one of us and explaining the procedure to them. Maybe they haven't kept up with the newest guidance, et cetera. And so sometimes it's just a matter of a phone call and explanation. The other thing is too, the new guidance is not released yet. So please don't think everything you heard today is going to happen tomorrow. The guidance is still going through the review process for the siren.
And I do want to just thank you, Karen, and Deb and Dr. Kennard, because you have assisted us as the Ombudsman Program and directly contacting facilities that we've had that struggle with. Because Kara, what you see, we also do see as well in the Ombudsman Program. We do see kickback sometimes from the facilities, and that simple phone call has made some difference. And so we want to thank you for that, because that was important. I know a couple instances that pop into my head where some people's lives were drastically changed because of the interventions that one of the three of you have been able to provide at that given instance. So I really do want to thank you for that, because you have made a difference in the work that you are doing.
And I will second what Lee just said. I can email or text them and they do help. So, but at the same time, how do we make sure when this guidance comes out that the counties understand, or this, whatever your local health department is, that they need to take this into consideration. All of these counties that are just shutting the whole county down. Or, Adams County was over 2 months of nothing but outdoor visitation. And I realize they are the boots on the ground, but they're not you guys either. So it's a real hard answer for the local facilities and the families to understand why CMS issues, you guys issue, and then the county does what they want. How do we make that more cohesive to have less of that issue? We're going into winter. It's going to happen.
Carrie, I'm just going to say this, Karen. We hear you. We'll take that back, discuss it amongst ourselves to see if there's any opportunity to continue. Dr. Kennard does an excellent presentation every week with the local health department. So perhaps that's another opportunity for her to, make sure and reinforce, et cetera. But you have to remember that Illinois is the home rule in the sense that local health departments do have jurisdiction.
No, I do understand that, and I try to explain it to people. It's just, it is very difficult at this end.
New guidance did, I'm going to say, open the door, so to speak, for lack of a better word, no pun intended there, and because of people being vaccinated, really emphasizing the vaccination and how important it is and how effective it has been, and then hopefully changing our behaviors because of it. And so I think you're going to be pleased with some of the changes that are going to be made.
And I know we've neared the end of our time. We've actually gone over a little, and there has been some comments about vaccination and vaccination for all and all that. And that's why I do feel that the information that you shared regarding vaccination, I know one of the questions that I've heard many times have been about, well, it came out so quickly with this vaccine, that how safe could it really be? And it was very important, I think, for us to hear that this wasn't something that was developed within a matter of 6 months after the whole COVID thing started, that it had been going into play for about 18 years, since 2002. So that information that you did share, I think one of the things that does keep getting repeated is that the vaccination is the key to making sure that all of these issues and these questions that we're experiencing all just disappear. So that information was empowering for all of us to be able to receive that today. That was really important information. So we will take, because even that website, that VAERS, I'm not sure how you say that, that was important. We will make sure that all the links that were provided in the presentation today, someone asked to post them on Facebook. We will do that, as well as the slides. We do, if we could please get those. Well, actually, I have the slides. What am I saying? And I will make sure that they get posted onto the Ombudsman Resident and Family Support Council page, so that you have access to that, as well as this recording. That will also go on to our website as well. We are experiencing a little difficulties with getting the videos up onto our website due to the length of these videos, but we're strategizing, and we are coming up with a plan to make sure everyone has access to this. So again, I want to say thank you to everybody. I'm going to put a quick poll up. If you could please answer the poll. If you could, I'm going to put it up right now. If everyone could please answer this poll, it's just helpful for us to be able to get to understand the types of questions that you want, any topics that you would like moving forward. Please feel free, put those into the chat box. And if you could please also put your zip code in, we'd like to track where people are participating from around the state. So if you could put your zip code into the chat box, that's also would be helpful for us as well. And once again, I really can't thank Deb and Karen and Dr. Kennard for being a part of these calls, for helping to keep us empowered with information through this pandemic. This is the 4th time that you have been on with us, and we truly appreciate the work that you're trying to do to keep our residents that live in our long-term care facility safe. So thank you very much for that. With that being said, I'm going to go ahead and I'm going to turn off the recording, but I will be staying on. So if anybody has any questions, please feel free to pop those in. And if I can't answer them, I will make sure that the powers that be do get those. So thank you very much, everybody. Have a wonderful afternoon. And we look forward to hearing you at on our next call, where we'll be talking to an administrator and a CEO and a family member about what their experience is about with person-centered care and how you can make sure that you get that for your loved one. So thank you very much. Have a great day.
Hey, Lee.